Good evening, everyone, and today we are covering the uh, pharmacology of drugs for disorders of the respiratory system. And there are two uh, diseases, asthma and COPD, and these diseases have the same way of the treatment, but the reason for these diseases is completely different. So first let's start from the asthma, and asthma is a disease uh, that is mostly depends on mast cells. So mast cells are the reason for the asthmatic patients. So mast cells are activated by the allergens that are inhaled, and they go through the epithelial cells, and then uh, with the different factors they will activate the mast cells, and that will uh, also make mast cells to activate dendritic cells, and also dendritic cells can be activated by the agent themselves, by the allergen themselves. So, and dendritic cells can also activate the helper cells, and those cells will activate the B cells, and that and also eosinophils. And eosinophils play an important role in the inflammation, and uh, that further can increase the inflammations in the lung and activate the mast cells, and also beta cells also will activate the mast cells, and that will further increase the progression of the disease. So this is for the asthma, and for the COPD, or chronic obstructive pulmonary disease, the reason is usually cigarette smoking or other irritants from the air, like the coal dust and the wood dust, that can make some irritation, but most commonly it is cigarette smoke, and that smoke will lead to the uh, activation of the monocytes, and monocytes will actually uh, produce the macrophages. So the tissue form of the monocyte is a macrophage, and macrophages will eventually activate the neutrophils, and those neutrophils will produce proteases that will lead to the secretion of the mucus, that will further obstruct the airways, because the airways here are already obstructed, and that also will lead to the uh, alveolar wall destruction, that will eventually lead to the necrosis. So, and then the lung function decreases eventually, and also macrophages will activate the T lymphocytes and fibroblasts, and fibroblasts will lead to the fibrosis that will damage the walls of the uh, lung, the bronchioles, and further lead to the inflammation. So and so this is actually the way the COPD, or chronic obstructive pulmonary disease, will progress. And if we look at the mast cells, so this is if we look uh, uh, closer to the mast cells under the microscope, for example. So there are many things that happens, many things. So actually, so let's get into it. So as and so this is a mast cell, and the mast cells are activated by the antigens from the air. So usually this can be smoking, tobacco smoke, or any allergen in the air. And after the activation of the antigens, so mast cells, they have uh, antibodies for these antigens on the surface. So and they activate and release a histamine. The histamine will bind to the histamine 1 H1 receptors at the surface of the smooth muscle cell and lead to the through the GQ messenger will lead to the increase in the calcium level inside the smooth muscles that will increase the contraction. So this is the at the beginning of the disease. So there is only histamine, but then we are also that the histamine will activate the phosphol, and also the muscles will activate the phospholipase A2 that will uh, uh, produce the leukotrienes and prostaglandins from the arachidonic acid, and the leukotrienes are going to activate the cytoplasmic LT1 or leukotriene 1 receptor and activate the GQ of protein to increase calcium again and lead to the contraction. And so these leukotrienes include the LTC4, LCD4, and LTE4. So they are all four, but different C, D, and E. So these are most important in the inflammation during the asthma or COPD. So and this also for another pathway of arachidonic acid is the prostaglandins or cyclooxygenase pathway. So leukotrienes is the leukotriene pathway. So and besides the leukotrienes, the adenosine is playing a vital role in the inflammation. So adenosine is also released by the mast cells and then activates the adenosine 1 receptor that is bound to the GI protein, and that will lead to the decrease in the cyclic adenosine monophosphate production, and so the and that will increase the contraction. So so adenosine itself is acts as a inflammatory mediator. So and then catecholamines also influence the smooth muscle contraction. So they relax muscles by activating the beta 2 receptors that are coupled to the GS protein, and that leads to the increase in the cyclic adenosine monophosphate and relaxation. These catecholamines include the epinephrine and norepinephrine, and they can be used as drugs. So, for example, epinephrine is used for the acute disease by the emergency team. And the drugs that can influence all these, so the catecholamines are actually produced inside. So all this is produced, that we mentioned before, is produced in the body of the human. But we also can use the drugs that influence the receptors that are located on the surface of the mast cells or the smooth muscle cells to help the patient with the disease. So, and the first drugs and drugs of choice are the beta-2 receptor agonists, and these are divided to two groups: slow-acting beta receptor agonists, or SABAs, that include albuterol and levoalbuterol, and also long-acting beta agonists, or LABAs, that include arformoterol, formoterol, vilanterol, and salmeterol. So these are the beta-2 adrenergic agonists that activate the beta-2 adrenoreceptor at the surface of the smooth muscle cell. Then there are also the muscarinic antagonists, that are divided to two groups: short-acting muscarinic antagonists, or SAMA, that include ipratropium, and long-acting SAMA, that include tiotropium, aclidinium, and umeclidinium. So these drugs block the muscarinic M3 subtype of receptor at the surface of the smooth muscle, and that prevents the acetylcholine activating these receptors and increasing calcium inside the smooth muscle cells. Then there are also anti-leukotriene drugs, or leukotriene modifiers, that include montelukast and zafirlukast, and these two are the leukotriene receptor antagonists that block the cytosine leukotriene receptor 1, and that prevents the leukotrienes C4, D4, and E4 to activate the receptor, and that reduces the contraction. And also they include xylitol, that blocks the leukotriene oxygenase enzyme that produces the leukotrienes. So these are the leukotriene modifiers, or the antagonists of the leukotrienic receptors or enzyme, so oxygenase. So, and the next group is the phosphodiesterase inhibitors, that include the theophylline and roflumilast. So the roflumilast is the new one. So theophylline is the inhibitor of the phosphodiesterase, and that inhibits the phosphodiesterase that decreases the cyclic adenosine monophosphate. So actually consumes cyclic adenosine monophosphate that leads to the contraction. And roflumilast is a selective phosphodiesterase 4 inhibitor, that so the type of the phosphodiesterase in the smooth muscle is type 4, so it is more selective for the more smooth muscle cells and has a better adverse effect profile than the theophylline, because theophylline is actually very toxic and produces much adverse effects, and that limits the broad application of the theophylline. So, and also there are antihistamines. Antihistamines are drugs for the anti-allergic drugs, and the antihistamines block the H1 receptors, and then they prevent the histamine activating the smooth muscle cells. So we will discuss antihistamines in detail later. So the most expensive drugs of all these is omalizumab. Omalizumab is an antibody for the IgE or immunoglobulin E. So, and this antibody prevents the IgE binding to the receptor. So, and that is actually prevents activation of the mast cells. So that is more effective than any other drug, because we prevent the antigen at the beginning. So however, omalizumab is has a limited application because of the adverse effect, and also the route of application is only slow intravenous, and is very expensive at the moment because of the monoclonal antibody. So it is a monoclonal antibody, and that is why it's very expensive. So these are the drugs that are used for the treatment of the asthma and COPD. And also we will discuss there is one group that is not mentioned here. It is the glucocorticoids, and glucocorticoids are the anti-inflammatory drugs that increase the synthesis of the anti-inflammatory, increase the activity of the anti-inflammatory genes to increase the anti-inflammatory production, and also decreases the inflammatory genes to decrease the inflammation or activation and inflammatory messengers production. So, and they are synthesized in the body, but also can be given orally and injected, so in high concentrations to decrease the inflammation. So they are very effective anti-inflammatory drugs, and the reason for this is, like, in low doses, corticosteroids will usually, so what happens during the inflammation? So some inflammation are like interleukins 1b or tumor necrosis factor alpha will go through the cell membrane, and then will activate one of the nuclear factor kappa B or other factors. So, and then that will eventually lead to the activation of the inflammatory genes, for example cyclooxygenase 2, and will lead to the transcription of these genes and production of the enzymes. So the corticosteroids in low dose bind to the glucocorticoid receptor that is located in the inside the cell. They bind to the cytosolic receptor and then go to the nucleus, and they prevent the deacetylation. So they prevent the deacetylation and transcription of the genes that will prevent the production of the inflammatory uh, enzymes. So, and this is a low dose, and then in high doses, the uh, the corticoids will also produce, and so they also bind to the glucocorticoid receptor, and additionally they will produce an anti-inflammatory genes, so they will acetylate the anti-inflammatory genes, and that will produce the anti-inflammatory substances, so like annexine or A1, for example. So, and this will block the phospholipase A2 and prevent the formation of leukotrienes and prostaglandins that both can be inflammatory. So actually that is very effective because it is before the cyclooxygenase. So in low doses they will inhibit only cyclooxygenase, but that will leave, for example, like leucooxygenase pathway, but in high doses they uh, prevent the activity of the phospholipase A2, and that is very, very effective. So, and there are two types of the corticosteroids that can be used for the treatment, or the inhaled, including the methylmethazone, budesonide, cetirizine, fluticasone, mometazone, and triamcinolone. So these are used by inhalation, uh, and also the oral tablets include dexamethasone, methylprednisolone, prednisone, and prednisolone. So these are the uh, systemic orally taken drugs are more effective and more side effects. Inhalation are also effective but less side effects. Uh, because of the uh, they they don't they are not absorbed, so they only uh, yeah, will only influence the bronchioles because of the topical action of the bronchioles. So, and that is it for today. Thank you for your attention, and hope that will help you to prepare for the class, because this topic will be ahead, so this lecture is ahead of the classes. And eventually this is the last lecture in this semester, and I'm glad that we are together, and actually so will I hope to see you at the practical classes during the semester, and the next year and the next semester in the new year after the January as well. So thank you very much for watching, and see you next week. Bye bye.